Hey, everybody, and welcome back to the podcast. This week, we're going to talk about something interesting that came up in a discussion on one of the Facebook communities that I frequent. When is cardiac monitoring necessary when it comes to doing patient pain management? Is it even necessary entirely to begin with? And what are the benefits from doing so? Stay tuned. So the discussion that we had was focused around a particular instance that had occurred to a colleague of mine. And I'd just like to share this discussion here quickly with you. So discussion that was posted, and just for the sakes of privacy and anonymity, I blurred out the name and who posted it. But the discussion that was had was this, and I'll read this scenario for you. While watching a high school football game tonight, I noticed a gathering of people at the arrival of a police officer. I offered my assistance. The patient has an obvious deformity to the left knee, dislocation most likely. 13-year-old MOI moving from one step down to another, and a knee gave out. Other than obvious deformity, nothing else relevant to the patient or situation. Fire department response with 5 members. I provide brief handoff and move away. I occasionally glance over. I notice a provider drawing up a medication into a syringe and recaps the needle, then attaches an atomizer. We move off and see our daughter at the other end of the field and return 15 to 20 minutes later, and the crew is still present with the patient. After another 5 to 10 minutes, the ambulance arrives. 30 to 40 has lapsed so far. The patient is carried out and stands on a soft stretcher to cot. The patient appears fairly snowed. My wife remarked the patient looked sound asleep. I was surprised there was no obvious monitoring equipment attached to the patient. So, from my point of view, I was not impressed with what I observed. This was not a life-threat situation, and yet it seemed painfully slow and lack of attention to detail. I wonder if this is typical practice. So, what I get out of this situation, there's a couple points that were raised that are interesting discussion points. Primarily, what interests me is the discussion about whether cardiac monitoring or what sort of monitoring is necessary when you have a patient that you're undergoing pain management with. Now, my knee-jerk reaction to this discussion is, cardiac monitoring is a reasonable and sound idea. Some other people had different opinions, and some of their opinions were, and I quote, absolutely not typical practice, but a great way to potentially harm a patient and get yourself sued. Is that necessarily the case? What's the actual harm that can happen? How exactly would not having a cardiac monitor harm your patient? And are there other methods of, say, visual assessment that could identify any potential harmful effects? And what exactly is the morbidity or mortality of these medications that we're giving and associated sequelae? So, let's talk about a couple of things. So the pain medication that is typically administered via intranasal route is usually going to be something along the lines of fentanyl. Morphine has a pretty poor bioavailability going by the intranasal route. Typically only about 10% of the administered dose is bioavailable. So it's going to be a different medication, but looking up the effects of, say, morphine in EKG changes, you'll find literature that suggests that it has some nonspecific ST segment changes and maybe some QT prolongation. Can lead to things like AV junctional blocks and things like bradycardia. But a lot of those toxic effects on the EKG from the morphine isn't so much directly a result of the morphine, but other metabolic changes related to, say, hypoxia from hypoventilation. So the effects of morphine in standard EMS dosing is actually fairly minimal, in fact, almost no appreciable impact on the EKG that you can notice. So the benefit of cardiac monitoring is really minimal. In fact, I would posit that if you are looking at a cardiac monitor to tell you when your patient has gone apneic, you've already missed the boat by the time that they become bradycardic, so you can notice. There are other methods that you can use if you don't want to strictly observe your patient, that you can monitor your patient's respirations. For patients who I tend to sedate heavily, I would definitely undergo end-tidal capnography monitoring. That way we can continuously monitor respirations to see if they are becoming bradypneic. And that's not a bad idea, especially in someone who we use, say, heavy doses for agitation or excited delirium, or who has significantly painful injuries that require heavier and higher doses of pain management medications. So I think maybe end-tidal capnography is not a bad idea, but EKG monitoring, I'm not sure we're going to derive a lot of benefit. So to say that it's harmful and deleterious not to have a cardiac monitor, I think is somewhat absurd. But there's other points that were raised, and good discussion points as well. Some of the discussion points that were brought up appears to be things like recapping the needle, which a lot of people would suggest is maybe a suboptimal practice, but it's something that can be done safely and appropriately given just standard precautions. In fact, the only time that I've really had an issue with recapping a needle was when I was actually, it wasn't so much even a needle that I was recapping, it was just the syringe itself. I had a a bit of an exposure not too long ago where I was reaching for the cap from a saline flush to cover up a syringe that still had some balance remaining of morphine. Well, unfortunately, as it so happened, we were traveling down a rather bouncy road, and we hit a bump, and my arm stabilized myself, but it caused the plunger to depress just a fraction of an inch, enough to squirt a little bit of the balance of morphine into my eye, which is not as fun as it sounds, especially from a paperwork standpoint. The quantity that I would have received would be nowhere near any sort of impact, but it's enough to cause a hassle with the paperwork. So always be mindful as to what you stabilize yourself with, especially what you're holding in your hand. So other than that embarrassment, recapping a needle can be done safely, and it's not necessarily harmful, especially when you're talking about a medication that's been drawn up, not as far as used needles. Those obviously should never be recapped. But the other issue that was talked about was things like time frame. I'm less concerned about time frame on scene, especially when we are actively doing patient care. Someone's injured, they have a knee injury, and if they need pain management, we'll take as much time as we need to get that pain management done on scene right away. The goal is faster time to pain management, not faster time to getting to the ambulance, where pain management could be later established or maybe not done at all, depending on provider preference, unfortunately sometimes. But spending 10-15 minutes on scene to manage the pain and get it to an appropriate threshold before you start moving the patient is not a bad idea. In fact, it's something that I would encourage. The other discussion is obviously the discussion about this being a knee injury. And there's a couple of different types of knee injuries or knee dislocations. There's ones that involve the actual knee joint itself, and there's ones that actually involve just the patella. And if they involve just the patella, the fastest and most effective method of pain relief is actually to reduce the dislocation. It's something that can be done safely and effectively in the field and provides near instantaneous relief. Obviously, if this is not something that's practiced in protocol in your area, that might not be something that you can achieve. But in the New York region, we have established protocols for reduction of patella dislocation, and that can provide near instantaneous relief. So if that was the case, I'd say that might be a better option than, say, utilizing morphine or fentanyl for pain management. A reduction of the dislocation will almost instantaneously relieve that pain. And if there's still residual pain after that point, you can definitely provide some analgesia at that point. However, morphine, fentanyl, opioid pain management doesn't really prevent the perception of pain when it's an acute pain. If you take a whole bunch of, say, morphine or fentanyl and you hit your finger with a hammer, it's still going to hurt. It prevents less of the acute pain transmission and more of the slower pain transmission. So the effect of fentanyl on reducing the pain of the dislocation is not going to be substantial. The other issue is, what kind of knee dislocation is this? If it's not a patella dislocation, there's other types of knee dislocations that could potentially compromise the circulation and nerve function distal to that joint. Because of the way that the joint comes together, sometimes some of those vessels can get pinched in a dislocation, and that could actually be a life or limb, or, well, literally limb-threatening emergency. So I'm not entirely certain whether that'll be the case here or what exactly transpired. But it's just an interesting discussion point. Now, obviously, it's hard to predict how long EMS response should take on scene, especially if you're talking about having, a tiered response model where you have different modes of response. So if it takes, say, 15 minutes for an ambulance to arrive on scene after the first arriving personnel, that might be the typical procedure or the typical way that a system operates, but it might not necessarily be the most efficient route. But that's not really so much a clinical discussion as more of an operational discussion, which is outside the scope of what we're handling. But to recap, pain management, is cardiac monitoring really absolutely necessary? It's not a bad idea, but if you're relying on your cardiac monitor to tell you that your patient has gone apneic and has now bradycardic as a result, you've missed the boat. Absolutely use all the tools that you have at your disposal, but is cardiac monitoring really absolutely necessary? Evidence says maybe not. But that's all for this week, folks. Join me next week. I'll see if I can pull up some interesting content for you. As always, keep thinking differently.